Hello, good afternoon. Can anybody hear?
Yes, we can hear you.
All right. Sorry, I could not deliver this lecture in the theater hall because was having some flu-like symptom and ongoing cough. So don't want anyone to be affected. Right. Okay. I think we have, how many members do we have until now? It's 4 people now. So should we wait for some time before we start? Can anybody see the slides? Hello? Can anyone see the slides? Hello? Can anybody see the slides? If anyone can confirm.
Hi, yes, I can.
The moving slide.
Yes.
Shall we give some time if more people want to join? Hello, everybody. My name is Anwar. I am one of the rheumatology registrar in Lincoln County Hospital. I'm ST5. Today, our topic is about vasculitis. This is the thing that we sometimes see in the departments, in the wards, with people coming with a rash. They are coming with the headaches and all other symptoms. So it will be very basic knowledge about the vasculitis. We will go through the definitions, the classification, risk factors, workup, sign and symptoms, and the latest treatment guidelines. Is everybody's hearing? Is voice is clear?
Yeah, we can hear you.
All right. Okay. Brilliant. So the thing is the definition, what the vasculitis is. So it's an inflammation, very simple thing, inflammation of blood vessel. Uh, any blood vessel, any part of the body can be affected with the vasculitis. So during the vasculitis, what happens when the body immune system tries to they attack on the blood vessels, and during the blood vessel when they attack, so they cause the uh, some inflammatory changes inside the blood vessels. So as a result of the blood vessel inflammatory changes, the two things can happen. The first thing is there is a formation of thrombus, and when there is a formation of thrombus, the blood supply to the distal arteries and the distal organ, it is obliterated. So that's why sometime when there is a thrombus and the organ gets the infarction, like a stroke in the younger patients. The other thing is other consequence of the vasculitis is the rupture of blood vessels. So when there is a rupture of blood vessels, second is to inflammation, and then there is a bleeding. Bleeding occurs. So you can see the picture on the left hand side, and the where you can see that there is a multiple hemorrhages. You can see on the both lower part of the legs. They are very typical of the vasculitis, and this is caused by the bleeding from the inflammation of the blood vessels, and then can be very obvious on the skin. The picture on the right hand side, you can see the temporal artery uh, inflammation. So when there is a temporal artery inflammation in temporal arteritis, we also call it joint cell arteritis. There is inflammation of the headache and inflammation of artery, and due to this inflammation, the artery become tender and it become tortuous. Also, this is extracranial, the picture. The one of the branch is intracranial that supplies to the eye. And if there is inflammation in that eye, the people can also having the blurred vision. And if there is a thrombus formation, and there is a risk of loss of the vision. So this is basically a vasculitis. So in any kind of vasculitis, mainly there are the two uh, things ongoing with him. Either there is a formation of thrombus that leads to infarction, or there is a rupture of blood vessels and then leads to hemorrhage. Next is classification. There are different kind of classification, different ways that we can classify them. We can classify them depending on the size of the blood vessels, large vessels, medium vessels, and small vessels. We can also classify the vasculitis on the base of ANCA, anti-nuclear antibodies. So we will see the first we will do go through the vasculitis classification based on blood vessels. So we have large vessel vasculitis, we have small and the medium size vasculitis. So in the large vessels vasculitis, we have the two main diseases that is called the giant cell arteritis. We also call it temporal arteritis. That is commonly seen in A&E or in Aztec. The other thing is Takayasu arteritis. That is almost the similar things to giant cell arteritis, but it happens in the younger patients rather than in older patients. Giant cell arteritis is comes in normally happen after the 50, and with advancing age, the risk of getting the giant cell arteritis becomes more and more. Then we have a medium vessel vasculitis. We have polyarteritis nodosa, we call it PAN, and the Kawasaki disease, and this is most common in the children. The next one is a small vessel vasculitis.
Hi, sorry, Dr. O'Hack.
Yeah.
We can't actually see your presentation here at Pilgrim. Would you mind just stop sharing it and then reshare it again, if that's possible?
Yes, why not? So you can't see the
Thank you.
presentation.
No, can't see anything. Just a
can't see-
little icon.
So no slides are ongoing.
No, not at the minute.
Right. Okay. So let me then stop sharing this one, and then I can start the reshare with this one.
So we still can't see anything here at the minute. We'll leave and join back and see if that fixes it.
Yeah. Try to see it. Can you see now?
No, still can't see anything. We'll just leave and join back. We'll just be a sec.
Yeah, I think let me try the other way then. Oh, yeah, initially they could see, but sometimes it doesn't. But this will be the smaller version. Is that okay? Visible on team. Oh, can you see now? Hello?
Hi, yeah, that's perfect. Thank you.
All right. Okay, brilliant. It should be moving on. Well, okay. So we were on here. We were on the classification of the blood vessels. Classification of the blood or the vasculitis can be on the different ways, but the most commonly used is the large vessel vasculitis, the medium-sized vasculitis, and small vessel vasculitis. And then in the small vessel vasculitis, we have ANCA, ANCA-associated vasculitis. We also say them AAV, that has vaginogranulomatous, Church-Strauss syndrome, and microscopic polyangiitis. Henoch-Schönlein purpura, that is sometimes seen in the children's and also seen in adult. Cutaneous leukocytic angiitis and cryoglobulinemia vasculitis secondary to the infection like hepatitis B, most commonly B or C. So this is the one way to classify the blood vessels. And the next one is, all right, I guess maybe we need to move it one by one. The next thing we can classify them on base of ANCA-associated vasculitis. So ANCA is antibodies that we normally detect and we normally request when we suspect vasculitis. So if it is ANCA-associated vasculitis, we have normally three further categorization. One is microscopic polyangiitis, that is MPA. Second one is Church-Strauss syndrome, that is used to be called previously, but now they are called it EGPA, eosinophilic granulomatosis polyangiitis, and then vaginogranulomatous, that used to be a previous name, and the new name is GPA, granulomatosis polyangiitis, and sometimes ANCA is also positive in drug-induced blood vessel inflammations. Other thing is non-ANCA vessel vasculitides. That includes a long list, including vasculitis associated with the paraneoplastic syndrome, with immune complex deposition, like in SLE, or like in good posture syndrome, Henoch-Schönlein purpura, Behçet disease, vasculitis related to lupus, or rheumatoid arthritis, good posture, Sjogren syndrome, drug-induced immune complex related, and infection induced immune complex vasculitis. So there are three ways you can easily classify them. We in also both ways we use them. Sometimes we use the large vessel vasculitis way, vessel size, and sometimes we also use them on the base of the ANCA. So what are the main risk factor for vasculitis? So right, there's a problem with the slides. It's not how to. It's not playing here. I mean, it's. Sorry, just I'm it's not playing here. Just few notes, perhaps more.
Can we stop sharing and reshare again?
Yeah, we can do that.
Yeah.
But this was the other way. Is the slide moving or slide still? They're still stuck on the one slide. All right. I think now it's moving. Right. What are the risk factor for the vasculitis? So the first risk factor is age. We really need to consider the age of the patient. What is the presentation and what is age of the patient? Because some of the vasculitis, they are very much common relating to the age, like a Burgess disease, that is a common in a younger man who are less than younger than 45-year-old, and the people who have smoked. If the patient is suspicion of IgA vasculitis, and then it is more common in children, IgA vasculitis henoxycolin purpura, that is common if the children they are admitted in the ward with a bilateral leg rash, a joint pain, everything, and this should be considered more IgA vasculitis rather than the others. Giant cell arteritis, as I previously mentioned, that it's more common in people who are older than 50, and it's going more and more if the patient with advancement of age of the patient. If someone comes with a headache less than 50 or less than 40, a unilateral headache and temporal arteritis and temporal headache and tenderness, it's unlikely that the patient have giant cell arteritis or temporal arteritis, because the new criteria for ACR to enter into the giant cell criteria is age. That is the patient very rarely can also have, but it's unlikely to have the another to have the patient temporal arteritis who are younger than 50. Kawasaki disease, that is medium-sized vasculitis, as we earlier know, and it's more common in children. Takayasu arteritis, it's the common in younger as well. It's also vasculitis, so large vessel vasculitis. So GCA is also large vessel vasculitis that is common after the age of 50. Takayasu arteritis is also a large vessel vasculitis that is common in younger people. Next risk factor is family history. There are some vasculitis that runs in the family, like a GPA. Previously, we used to call it vaginal granulomatosis, Behçet disease, and Kawasaki disease. These are the few vasculitis that normally they tend to run into the family. The medication, but the people they are taking the medication that can also induce a vasculitic type reaction. The more common medication that we have encountered is hydralazine, levimazole, propylthiouracil, allopurinol, and TNFIs. If the patient is on these medications and they develop a rash or joint pains, other things, then and suspicion of the vasculitis, then these medications should also be considered the possible cause of the vasculitis. Next is ethnicity. There are some vasculitis, they are common in other areas. For example, sorry, Dave, let me go back. For example, the Behçet one, it's more common in the people of Turkish origins, and especially in the Middle East, Central Asia, China, and the Japan Silk Road route. Previously, you might have heard about this one. So this disease was used to be common on that one. So mostly the people who from the Mediterranean area, Middle East people, and the Turkish people who comes with features of the vasculitis, Behçet disease should be suspected in them. Giant cell arteritis, it's much more common in Northern Europe ancestry. It's also frequently encountered in the UK, but it's more common in European sites. It's less common in Asian sites. Kawasaki and Takayasu disease, the both of them, they are more common in Asian, especially in the Japanese side. The lifestyle is another risk factor. So smoking can lead to development of the Berger disease using illegal drugs such as a cocaine. That sometimes we encounter the patient who comes with a nasal perforation and the cocaine induced the vasculitis. And they also come with the loss of nasal bridge, nasal perforations, and the features. In these patients, we also encounter that ANC, ANCA is positive and with the PR3 positive. But this is one of the potential cause of the vasculitis and that should be considered in the people. We'll talk about the symptoms now. So we have general symptoms. So in the general symptoms, we normally, when the blood vessel get inflamed, they release a different kind of the cytokines and the toxins, and they get into the system, and then they give you the different kind of the features. The fever, patient can have the present with the fever. Fever could be a mild to moderate grade. It's not often the high grade fever. Patient can have a night sweats. It's also because of the inflammatory response that's ongoing in the system, and they can also present with the malaise and the weight loss. And these are not very specific features, but they're general constitutional symptoms secondary to the inflammation that is ongoing in the system. Patient can have arthralgia and myalgia. So these are the four general symptoms normally we can see, but these features you can also see in patient who can have infections sometime in the body, and the patient with the malignancy, they can also present with all these four symptoms. Laboratory features that are the common and the patient can have the normocomonomocytic anemia. We call it anemia of chronic disease. Leukocytosis and thrombocytosis. These are the two things that normally present in people who have the features of the vasculitis. If the patient have leukopenia or thrombocytopenia, then different diagnosis should be considered. So these are due to the inflammatory reactions, raised ESR and the CRP. So these are the general symptoms and laboratory general findings that we see when we run initial investigations and we try to find out is it really vasculitis or something different ongoing with the patient. Sorry. Then we have the more specific symptoms. As previously I explained, that the more specific symptoms that can come with the two outcomes. The first is the thinning of the blood vessels. When there is a thinning of the blood vessels and the blood vessel become more and more prone for the rupture. So blood vessel has increased permeability, they can easily rupture, and the hemorrhages can affect into different part of the systems. So commonly we can see under the subcutaneous hemorrhages that present as a petechial hemorrhage and the palpable purpura. Other one we can see in alveolar hemorrhage that we normally see in GPA, granulomatosis with the polyangiitis, previously used to call Wagner granulomatosis. The patient can present with this one. Hematuria can also present when there is a bleeding in the urinary tract. These are the few things that normally we see, commonly we see when the patient present with because of thinning of the blood vessel. And the next is narrowing or complete occlusion. When there is a narrowing of the complete occlusion, and then the distal organ can suffer into infarction. So when there is a giant cell arteritis and there is occlusion of intracranial blood vessels, and then patient can present with a stroke. Younger patient stroke, we normally run all these investigations to find out the possible cause of stroke, and this is one of the things that the vasculitis could be the possible cause of the stroke. Myocardial ischemia can also present sometime because of ongoing inflammation, and this is because of the large vessel vasculitis that affecting the aorta and sometimes the cardiac branches. Ischemia, intestinal ischemia is also one of the presentation that can that can be one of the manifestation in the patient when there is a suspicion of vasculitis. So these two things, either thinning of blood vessel, they can lead to hemorrhages, that can lead to purpura or petechiae under the skin, and the narrowing of the blood vessel that can further lead to ischemia and infarction of the distal organs. So this is one of the picture you can easily understand. Is the normal artery, that is the way the blood flow is very good, lumen and diameter is fine, and then there is a narrowing of artery. So when there is inflammation in the wall of artery, and there is inflammation and there is a swelling of the artery, and then the lumen become narrow and narrower. And when there is a complete occlusion and the blood stops flowing in distally, and then there is risk of infarction or risk of ischemic pains. On the other side, it can also cause the formation of aneurysm because of the thinning of the blood vessel. When there is a thinning of blood vessel, there is a risk of the formation of aneurysm. So aneurysm, their formation is the most common polyarteritis nodosa and some other disease, and there is a risk of a rupture of these aneurysm and can lead to a massive hemorrhage. So these are the symptoms when we see the patient in our clinic. We usually go through system one by one. I preferably go through the skin first because this is the most obvious organ that you can excuse me, you can see in the patient. You can ask about the patient if you have any palpable purpura or livedo reticularis, and then you can go with the joint pains, ask about the joint pains, if they are suffering with the joint pain, joint stiffness or inflammation, joint swellings. Then you can ask about the nervous system, any previous history of a stroke or dizziness or TIA symptoms. Eye symptom reduce visual acuity. That is one of the important things to you when you suspect giant cell arteritis, that you need to ask this question as well. Nasal bleed, it's common in GPA, granulomatosis with cholangitis, ANCA-associated vasculitis. It's common with the nasal bleed, with the nasal crusting, and there is a risk of the perforation of nasal septum. Hard myocardial infarction and hypertension is another one. Symptoms, they are more specific in related to the vasculitis. Lungs, so patient can present with a massive hemorrhages, pulmonary hemorrhages, or patient can also have the hemoptysis. Patient can have shortness of breath, and in EGPA, eosinophilic granulomatosis polyangiitis, patient can also have wheeze-like symptoms, and that are responding to very well of the steroids. Digestive tract, patient can have blood in the stool and can have abdominal pain. So this abdominal pain is ischemic in nature because of the inflammation of the blood vessels. And the GIT tract is not getting the good quantity of blood, and then can give you the the pain. Kidney glomerulonephritis, Gold-Bostic syndrome, GPA, and more microscope polyangiitis. These are the things that most commonly involve the kidney as well. So proteinuria is also common. Microscopic hematuria is also common. So when the patient comes to the clinic with suspicion of the vasculitis, or who are already diagnosed with the vasculitis, we always ask them to provide us a urine to find out is it still having hematuria or or proteinuria, because this can affect the kidney in the long-term disease. Muscle aches and the pains and the general symptoms, we have already reviewed this one. So patient can present with the general symptoms, but they are always very non-specific, and they can also be in other disease presentations. More specific symptom, you can go through system to system. So starting with the skin, and then the joints, and then starting from the head to toe, CNS system, eye system, nasal system, lungs, liver, GIT, urinary tract. So this will give you a very detailed history, and you can ask all the features that patient can potentially have the features. So this is one of the particular hemorrhages that most of you have seen in the ward. The patient can present with these kind of the rash and with the suspicion of the vasculitis. But this is the presentation in the skin. So to rule out the cause of vasculitis, you need blood investigation and a proper history and more specific blood test that we will see in the later on. These are the two further pictures. On the left-hand side, you can see irregular tapering of the left subclavian artery. If you see the right subclavian artery, that has a very good diameter, but the left subclavian artery has a narrowed and there is the loss of the diameter. This is common in the Takayasu arteritis. So Takayasu arteritis is also called the pulseless disease. When you feel the pulse on the both side, you can have the pulse on the one side, but on the other side, maybe there is absence of the pulses because of the narrowing. So patient can present with pain in the arms and other constitutional symptoms, and then this can be diagnosed on angiography. And the next is the beaded appearance. Sometimes you can see a rosary bead appearance, and this is also more obvious on CT images. The picture number A is the same, particular hemorrhages with palpable purpura because they are the big one. The B is the livedo reticularis that you have seen in different kind of patient. They are the mesh networks you can see on the legs. The number C is the ischemic ulcers because of the loss of the blood flow. And then there is the formation of the gangrene. And on the other side is the ulcers. They are non-healing ulcers. And they are all just similar presentation like the venous ulcers. So it's difficult to treat them because there is no blood flow. Well, after the taking the proper history and investigations and clinical presentations and proper history, we will go for the workup of the vasculitis. So when you do a workup of vasculitis, you should think about these 5 possibilities. Not every presentation is vasculitis, but we must rule out these all things. The first thing is that we need to find out 5 questions you need to ask yourself. The first question is this condition that could mimic the presentation of vasculitis? Number 2, is this secondary to underlying cause? Number 3, what is the extent of vasculitis? Is it life-threatening or a non-life-threatening? How do I confirm the diagnosis of vasculitis? What specific and general test and images you need to run to diagnose the vasculitis or biopsies? What specific type of the vasculitis is this? So these are the 5 questions that you need to recall before you see a patient with the vasculitis. Is it really a vasculitis or is something else that is mimicking the vasculitis? Is there any underlying cause like ongoing rheumatological problems like Sjogren syndrome, SLE, systemic sclerosis, rheumatoid arthritis, and extent of vasculitis? These 5 questions, and then we'll go through one by one. So these are the common conditions that can also mimic the presentation of vasculitis. That infections, one of the major, the bulk in A&E, we admit many patients with a different kind of infections. Antiphospholipid syndrome that has recurrent thrombosis and sometimes can also present with the bleed. Thrombotic thrombocytopenia, TTP, that also present with petechial hemorrhages, thrombocytopenia. Sickle cell disease, embolization from the atrial myxoma, cholesterol emboli from atheroma, non-inflammatory vessel disorders such as fibromuscular dysplasia, amyloidosis, scurvy, and vasospasm due to ergo elements. So these are the few things. I think infection is one of the most common cause that we see in A&E. And then the TTP is one of the things that antiphospholipid syndrome is not that common, but if it is common, then normally the people they present with the SLE. And the other things, they are also not very common, but these are the few things that must keep in mind before you see a patient with a vasculitis. And if you're going to answer, is it really a vasculitis or not? The next is there any secondary underlying cause? So there are different secondary underlying cause that we need to consider. The first is inflammatory disease of unknown etiology. We discussed, I explained this already, the rheumatoid vasculitis, rheumatoid arthritis vasculitis secondary to SLE, Sjogren syndrome, inflammatory bowel syndrome, or sarcoidosis. Infectious diseases like most common hepatitis B and C that can lead to cryoglobulinemia, and then it can lead to vasculitis. HIV can also lead to vasculitis, mycobacteria, and the syphilis. Syphilis is very uncommon these days. Mycobacteria is still common. It's not common, but it still needs to be considered. Neoplasm, hematological malignancies like myeloproliferative disorder, lymphoproliferative disorder, and the solid tumors. Drugs that we already mentioned previously, hydralazine, propylthiouracil, montelukast, and allopurinol, and TNF alpha inhibitors. The third thing is if you think that this is vasculitis, and then we need to find out the extent of the vasculitis. Is it limited to the skin, or is it involving the vital organs, including the lungs and the liver, GIT tract, or the kidney? So it's very important to find out what is the extent of the vasculitis. If it is less life-threatening, because this will affect the treatment. This will guide us towards the treatment, what treatment option we are going to adopt. If the patient has a life-threatening one, so we have to go for the aggressive treatment management. If the patient has less limited presentation of vasculitis, then we have to go with the less aggressive treatment arm. That we'll discuss it later. So extent of the vasculitis is very, very important. We must find out that is it really going to threaten the vital organs, or is it limited to only some specific organs? And next, fourth question, we were saying that, okay, what is the histological and the radiological proof of vasculitis that should be obtained? In this case, we can run the different kind of the test. We can run the radiological test, we can run the CT scans, we can run the PET scan, we can have the biopsies. A biopsy can be taken from the skin. That is one of the most obvious organs. Sometimes we take the biopsy from the lungs and from the muscles. And temporal artery biopsy is one of the common things that we take to rule out the GCA or temporal arteritis. And then the treatment decision also depends on the same as I explained before. And in the patient with the skin and the renal biopsy is preferred. If the patient has a skin and the renal involvement, the patient is presenting with the skin manifestation of petechial hemorrhages or palpebral purpura, and you do a dipstick. And when you did a dipstick, you find out there is a proteinuria and microscopic hematuria. And then what site you will going to provide for the biopsy. So the skin will be the preferred one that we can go for the biopsy. So a specific type of vasculitis should be identified. So we must need to identify, because most of them, they have the different, the general treatment is almost the same, but the most of them, they have the initial different kind of the treatment. If it is a large vessel vasculitis, for example, if it is a GCA, we have to start the patient, find out the symptoms, history, if there is eye involvement or not, no vision problem, then we can start him on the steroid and then the tapering dose of the steroids. And if the patient is not able to wean off the steroids, then we can think about the other immunosuppressants like a DMARDs. A similar case with the medium-sized vasculitis. And then there is AAV, ANCA-associated vasculitis, that is GPA, EGPA, and MPA. These are the three vasculitis, and they have specific treatments, and then depends upon the severity of the symptoms. If it's more severe, we can go with the more aggressive approach like cyclophosphamide, methylprednisolone, and rituximab. If it is a less aggressive and no vital organ involvement, then we can go through prednisolone and the later on to maintenance dose to start with methotrexate or azathioprine. Infection-related vasculitis, we must rule out infection before we start to think about the vasculitis, because if it is infection-related vasculitis and we start treating the vasculitis, so potentially we will putting the patient at harm, because infection, when we give the steroid to the patient and the immunity goes down, and then infection can aggravate, and then it's very, very lethal for the patient. Underlying rheumatological disorder, the related vasculitis should also be ruled out. Previous past medical history is also very important. See if the patient is already known to rheumatology conditions like rheumatoid arthritis, Sjogren, SLE, systemic sclerosis, then we need to consider that is it vasculitis secondary to those conditions or not. So the specific type of vasculitis is important because we need to because they guide us towards the treatment. So here is a very brief summary where what we can do to rule out the vasculitic mimics. What can we do? And rule out the secondary cause. We can infection, as we told before, that is one of the most common cause. So you can run the septic screen, including the blood culture. Echocardiogram, you can do the echocardiogram because infective endocarditis can also give you the features similar to the vasculitis, splinter hemorrhages, petechial hemorrhages, the joint pains, and fever, weight loss, shortness of breath. So these all the symptoms are together the same. So we need to find out, is it vasculitis or is it infective endocarditis? Hepatitis B and C, HIV testing. Anti-GBM, Good-Bostic syndrome, that is we do in the Good-Bostic syndrome is mostly related to the renal rather than rheumatoid arthritis, rheumatology. Anti-phospholipid syndrome, and anti-nuclear antibodies. So these are the few blood investigation, and one of them is imaging that we need to do initially to see if it is vasculitic mimics or is there any secondary cause that is causing vasculitis. Then the next step is to assess the extent of vasculitis. So urine dipstick should be done in every patient. Microscopy should be done in every patient. The main aim is to see if the patient is losing proteinuria, or is bringing microscopic hematuria. Chest radiograph should be done in all the patients as a baseline, as well as the worsening of the condition. For example, we have vasculitis like GPA, granulomatosis with the polyangiitis that can cause alveolar hemorrhages, and that is one, and in MPA as well. Nerve conduction studies, electromyography, and CK level. So these are the things that we find out which what is the extent of this vasculitis. To confirm your vasculitis, the biopsy or angiogram, these are the two things that we normally do. Unfortunately, we do not have ultrasound scan available here in our hospital. And that is very, very much useful for temporal artery biopsy. So we have to rely on for biopsy. Sorry, we have to rely on the biopsy to make the diagnosis of temporal arteritis. We don't have ultrasound scan. If there is ultrasound scan, this has been much quicker and more convenient for the patient as well. Angiograms, we can run an angiograms. PET scans, sometimes when we don't understand, we can run the PET scan and we can pick up the inflammatory sites. To identify the specific type of vasculitis, the few further blood tests you can run. You can run ANCA, that is commonly requested. And if the ANCA is positive, and then the ANCA is mainly the two for the thing, P ANCA and the C ANCA, the central and the peripheral. If the ANCA is positive, then we run the two for the test, that is called PR3 and MPO. So if the PR3 is positive and ANCA is positive, then suspicion is high. C ANCA and PR3, it is much more specific for GPA, but the P ANCA and MPO3 is much more specific for MPO. So cryoglobulins, we request those complement levels. We also request complement level to find out the SLE, C3 and C4. Eosinophilic count, IgE levels. Eosinophilic count is much more in the Churg-Strauss syndrome previously, and the new name is eGPA and IgE levels. And we can also request IgA levels in Henoch-Schönlein purpura. And then there is some specific finding of the biopsies, like when the patient comes with a nasal perforations, we request a nasal biopsy to see if it is there is a necrotizing granulomatous inflammations that is very specific for the GPA, or presence of IgA deposits and complement fixation deposit for the renal and for the infection and SLE. So these are the few things that are the basic things that we need to go through to go for, is it really vasculitis or there is something else ongoing with the patient. So request these are the blood investigations and some images and the biopsies and the scans that we normally do to reach the diagnosis of vasculitis. And then the treatment, last thing is the treatment. So the treatment and the basic principles. The type of vasculitis depends on the treatment depends on the type of vasculitis. Is it a GCA? Is it Takayasu arteritis, or is it a GPA or EGPA or MPO Behçet disease, or is all depends on what type of vasculitis we have. So we will treat the patient depending on the vasculitis type. Of the vasculitis is also very important, and we discussed it before that we must know how severe is the vasculitis. Is it threatening the vital organs or not? If it is threatening the vital organs, so we go with the aggressive therapy. If it does not threaten the vital organs, or it's limited to the 1-2 organs, but the patient seems okay, so we don't go with aggressive therapy. We normally go with less aggressive therapy. So basic principle in the treatment of vasculitis is induction therapy. Initially, induction of remission. So when the patient comes and there is suspicion of vasculitis, and we have ruled out other secondary causes, and and then initial plan is to induce the remission. So induction of a remission is normally we do with the steroids. If it is not life-threatening conditions or not life-threatening organ involvements, but if it is a life-threatening organ involvement, we go with rituximab or with cyclophosphamide. And methylprednisolone can also be used, or sometimes we use the plasma exchange. And the next is maintenance therapy. Once we have induction the therapy, and we have done the induction, and the patient is in remission now, and then we need to control the inflammation. We need to under control the inflammation, and then we call the maintenance therapy. And that can be done with different DMARDs sometime. Yeah, if it's a less life-threatening condition, or this can also be done with biologics or with the cyclophosphamide. And refractory vasculitis, the patient is already on maintenance therapy, but he's still showing the signs and symptoms of vasculitis getting more and more active, and then we have to go back to induce again induction, to give him induction therapy again, and to bring him in the remission, and then to start the maintenance therapy. Some of them, they are very resistant to vasculitis, and normally we refer them to higher centers because we don't have any special vasculitic services here. So we need to refer them to the higher centers. These are the new guidelines that European guidelines that EULAR guidelines for treating the active GPA and MPA. These are mainly I focused on ANCA-associated vasculitis because these are the most commonly requested blood investigation in this hospital I have seen. And the other one is the GCA that I can discuss also. But these one the most commonly requested is one. So if the patient has GPA, suspicion of the GPA and MPA, and we have done the blood investigation, they are ANCA positive, and then they are PR3 positive and C-ANCA positive, PR3 positive, and then we see the extent of vasculitis and see if it is life-threatening one or if it is not the life-threatening one. If you go to the right arm and it's life-threatening, and then we normally start with the cyclophosphamide or the rituximab. So in combination with the glucocorticoids or avacopan. Avacopan is the new drug, is a steroid-sparing drugs that is mostly used in different hospitals. Unfortunately, it's not accessible to the rheumatology department in this hospital, but renal department, they are using avacopan here in this hospital. But we have to rely on the glucocorticoid until they give us approval to start the avacopan for the patient. So it is, if not life-threatening, we can start with the methotrexate with MMF, and then we can start with the glucocorticoid at the same time. If it is life-threatening, we have the option with the rituximab, cyclophosphamide with glucocorticoid, or with the plasma exchange can also be considered if they are not working. So once the patient is in the remission, normally we taper the glucose and glucocorticoid and we see if the patient is in remission or not. If the patient does not come in the remission with all the above therapies, then we need to consult the expert centers that unfortunately we don't have here. So we have to refer to the other hospitals. So if the patient is in remission now, and then we need to go for the maintenance therapy. So maintenance therapy can be in the different forms. So you can start either oral DMARDs like methotrexate, like azathioprine, or MMF, or you can also continue with rituximab as well. So sustained remission, yes, if it is on glucocorticoid or vacapon, you can stop them, or if it is on rituximab or azathioprine, you can continue to monitoring uh, for the blood investigation monitoring and the general condition of the patient and his sign and symptoms. If a sustained remission patient was in a sustained remission and he is relapsing again, then you have to reassess and restart the induction therapy. That could be in the form of methotrexate, cyclophosphamide, rituximab, or plasma exchange. So this is very basic concept when you see the patient with GPA or MPA. So glucocorticoid you can easily start once you have ruled out infection. So if there is infection, you must treat infection, because in the presence of infection, if you're going to give the glucocorticoid, this is more harmful for the patient rather than benefit. So rule out infection, rule out other common causes, and then if there is nothing secondary cause, and then we can really directly start with the glucocorticoid. So glucocorticoid normally we start with the 1 milligram per kilogram, or that is once a day with the PPA cover, and then once the disease is in remission, then we can start the tapering it off. Other things, you can also give the pulse dose of methylprednisolone 1 gram 3 days, and then start with the half dose of the prednisolone. You need to cover the bone protection as well, because normally these people have the long-term steroids. The next one is EGPA, that used to be called the Churg-Strauss syndrome. So this is eosinophilic. So we also, it's the same principle is the same, but the treatment is a little bit different. Principle is the same. So you have to find out, is it patient life-threatening or the not life-threatening? If it is not life-threatening, and we see if the patient is relapsing or previously treated, or is it refractory, then you have the option with the glucocorticoid or mepolizumab. Mepolizumab is recently approved for the treatment of EGPA. I think it was initially it was started in USA in 2017, and now the NICE has also given us to start the mepolizumab. Glucocorticoids, you can give cyclophosphamide if the life-threatening organ, and the patient is start tapering off the glucose when the clinical conditions start improving, inflammatory markers start improving, and the patient is in remission. Patient is in remission, yes, and then you can switch them to non-glucocorticoid medications, prednisolone, steroid-sparing medications like azathioprine, methotrexate, MEPO, or rituximab. So as long as the patient remain in remission, we continue monitoring the patient. So if the patient goes back to relapse or refractory to the treatment, and then we have to again go back and restart the cycle. If the patient does not sustain remission and keep going back, and then we need to refer to higher centers. So these are the very basic things that we normally do in our wards and with the patients. The patients, they are not that simple as you see in the slides. Yeah, thank you very much. This was very basic knowledge. So you must have understand the vasculitis and its presentation, and how to do the workup, and what are the mimics, and how to request for the angiography and all the things, and what are the basic treatment options that we consider when the patient comes in the department, and different kind of the treatment. The GCA, I think most of you must have encountered with the giant cell arteritis. Basically, patient with left-sided headache, sometimes with eye symptom or sometimes not with eye symptom. We start with the steroid when the symptoms stops, or when patient has normalized ESR or CRP, then we start taping off the steroids, and slowly and steadily. If the patient cannot tolerate steroids, the patient has some complication from the steroids, we can switch them to methotrexate or azathioprine. So these are the very basic the concept of the vasculitis. I hope you will not refer further patients to to rheumatology. All right, if you have got any questions, please, I'm happy to answer.
Thanks very much. No questions from Lincoln side. Thank you.
All right, wow. The Lincoln, the doctors, they are more intelligent now. Okay, thank you very much then. Yeah, I think you are maybe ready for the next palliative medicine teaching. Yeah, all the best. Thank you very much. Thank you.